So hello everyone. So today we will be discussing about a new topic called retinal artery occlusive disease. So what is retinal artery occlusion? So you have the retinal artery and its branches, right? So whenever there is an embolus or a thrombus which blocks these and obstructs the blood supply to the retina, that is what we call it as retinal artery occlusive disease. Okay. Now, first of all, before understanding things, let's discuss in detail about the blood supply anatomy of retina. If you see, mainly the ophthalmic artery is there, right? This is your ophthalmic artery. The ophthalmic artery will give its first branch called the central retinal artery. This central retinal artery will supply your inner retina. If you take retina, retina has 10 layers. 10 layers you divide into 6 inner layers and 4 outer layers. The 6 inner layers is supplied by your central retinal artery. So central retinal artery, after entering your retina, it divides into supranasal branch, supratemporal branch, inferotemporal branch and inferonasal branch. Then from the ophthalmic artery itself, you get another group of arteries called posterior ciliary arteries. In them, the main artery is the cilioretinal artery. This cilioretinal artery will supply your choroid. Behind your retina, you'll have the choroid, right? And from choroid through diffusion, it will supply the outer 4 layers of your retina. So this is the main blood supply anatomy of retina. This is very important in localizing the site of arterial occlusion. So coming to the etiology, so etiology of retinal artery occlusion is quite similar to that of the MI or stroke. Old age, male gender, smoking, hypertension, obesity, diabetes, hyperlipidemia, cardiovascular disease and coagulopathy. These are the more common ones. But one thing you need to remember is giant cell arteritis, which we'll discuss later. So coming to the pathology, what do you think the pathology can be? So you have your blood vessel, right? In blood vessel, you can have some emboli, which is coming from elsewhere. So this emboli will block the blood vessel and cause occlusion. The emboli in retinal artery occlusion of 3 types. Hollenhurst emboli. This Hollenhurst emboli is basically the cholesterol. Then what else can be the emboli? So platelets can be emboli, platelet plugs, and calcium. So these mostly this calcium thing will be coming from your plaques, atherosclerotic plaques, right? Cardiac valves, not the plaques, the valves. So Hollenhurst are the plaques, atherosclerotic plaques. Okay, then after that you have some thrombus formation. Some here itself you have some issues and thrombus formation. Then you have some inflammatory vessel wall damage. Then you have some traumatic vessel wall damage. So these are the pathology which can lead to retinal artery occlusive disease. Coming to the clinical features properly, the patient will be complaining of sudden, means over seconds. It occurs over seconds. Painless, there is no pain. Unilateral vision loss. So sudden, painless, unilateral vision loss over seconds. You need to suspect retinal artery occlusion because it is an emergency. So the patient will give past history of amaurosis fugax, which means that patient had some episodes of transient vision loss. So basically sometimes you have your blood vessel wall, right? So you have your blood vessel wall and sometimes it occludes and then it dislodges or some cannulation occurs. Because of that, again the vision once gone will be gained back. So because of that, the patient will be having amaurosis fugax history. And you need to note the age of the patient because that will help in prognosis, and you need to find the etiological causative factor and you need to treat that factor also to prevent further episodes, right? So because of that, you need to note the age of the patient also in history itself. Coming to the ocular examination. External examination, if you do, the eye will be completely normal. There will be no defect in the eye until and unless it is a traumatic. If it is a traumatic injury, there will be some defect. But until and unless it is a traumatic injury, there will be not be there any defect. Visual acuity will be reduced or normal. So most of the cases, the visual acuity will definitely be reduced because it will lead to the retinal artery occlusion. If you see the pathology, what happens? Let's discuss the pathology a bit. Occlusion will lead to ischemia. Ischemia will lead to edema. So whenever edema is there, the vision will be decreased, right? So because of that, visual acuity will be decreased. So in some cases it can be normal. In what cases can the vision loss can be normal? So before we saw the anatomy, right? You have the cilioretinal artery. Cilioretinal artery supplies your outer four layers of retina, and it supplies your macula also. If you see, macula derives its blood supply from these central retinal artery branches, but mostly it derives its blood supply from outer retina, right? Macula has outer retinal layers, right? Because of that, it gets most of this from cilioretinal artery. Okay, coming to the visual field, it will be variable. Okay, one more important thing to discuss is types of retinal artery occlusions. So here we will discuss the retinal artery occlusion types. Yeah, so if you are having occlusion in this particular area, what do you call it? You call it central retinal artery occlusion. Completely your artery is gone and you are having occlusion over this area, like this particular, whatever down it is there, it is gone. Occlusion in this area is central retinal artery. You have the artery supplying, that is occluded, that's central retinal artery. In this area you have hemiretinal artery occlusion, so your half of the field is gone. If you are having occlusion over this area or this area, this is some branch of your retinal artery, that will be your branched retinal artery occlusion. So central retinal artery occlusion, hemiretinal artery occlusion involves ischemia of half retina. Branched retinal artery occlusion involves ischemia of the part which it supplies. So this is your classification of retinal artery occlusion. Now, coming to the pupil. Pupil, you have your direct light reflex is absent and RAPD. RAPD is relative afferent pupillary defect is present. Okay, great. Coming to the fundoscopy. Now, fundoscopy is very important in retina, because fundoscopy forms the major part in diagnosing so many retinal conditions. So before we go to retinal artery occlusion, we'll see the normal fundus in very brief. So you have your optic disc, and from your optic disc you'll get your thick retinal vessels, your supranasal branch, supratemporal branch, and infranasal branch, infratemporal branch, and corresponding veins, right? And one more important structure, yeah, the macula. So this is how your normal retina looks. So, but when you come to this central retinal artery occlusion, what happens is your retina will become pale. So when your retina becomes pale, this is gone. 1 minute. So yeah, so that will be gone. So once that is gone, so what will be there? The retina will become paler. So this color, let us assume this color. So we need to mark one by one, and this is very important, and I want everyone to focus on this because this is very important in exams as well as clinical diagnosis, because this is what is the major thing rather than the clinical history. So your retina has become pale now. Next, on this retina we need to have your optic disc. Yes, I have my optic disc. Yes. So what will happen to your arteries? They will become very thin. Marked arteriolar narrowing will be there. So if you take your arteries, marked narrowing, you can see the arteries before and now, right? The difference. So marked arteriolar narrowing will be there. So I will mark this here itself. So you got pale retina first, then marked arteriolar narrowing is there. Next, what do you see? Next, you will see the veins. The veins will also become narrow, but not as much as arteries. So you can call them as mild narrowing, you can call them. Okay, mild venous narrowing. Okay, then two most important signs in this particular disease is what? So your retina is ischemic. And in macula, what do you see in macula? Yes, that is very important. What do you see in macula is very important. That is what you call it as, what do you call that? Yes, it is the cherry red spot. So I made a cherry red spot. Why do you think this cherry red spot comes? It's definitely because the retina will become so thin and the choroidal vasculature is visible. Choroid is behind retina, right? So you can see, right, the choroid is behind the retina. So this choroidal vasculature is visible. Because of that, that is visible as a red thing. So that is what you call it as cherry red spot. Okay, we are done with cherry red spot. One more important thing is, what do you see? The arteries in chronic situations, no, the arteries will become so much narrow that they look like what? What are these? So these are your thread-like arteries. Thread-like arteries. So when you are seeing thread-like arteries, no, you need to say that it is an atrophic change, chronic atrophic change. Means the patient already had some history of central retinal artery occlusion disease. So that is there. And one most important sign we missed out. What is that? Yes, that is your box scarring or cattle tracking sign. So this is because the blood it moves in form of small gushes rather than in a continuous column. So this is your important sign. What is that? Box scarring or cattle tracking sign. And here and there what happens to this thing is it becomes so much of ischemic and edematous that whitish areas appear. So you are seeing some whitish areas, right? So that is milky white retina because of artery occlusion. No, you are seeing that. No, that is your milky white retina. Milky white retina. So this is your main important fundoscopic image. This is must drawn in exam, as well as you need to observe this in real clinical images. Okay. So if we go through the fundus imaging now. Fundus imaging now we do OCT. OCT shows hyperreflectivity and thickening of inferior edema due to inferior retina due to edema. Obviously edema is there, because of that thickening will be there in OCT. Then fundus fluorescence angiography. You know that this is a time-based thing. What happens here? Filling of arteries, then artery venous transit, then veins, right? So artery is blocked. So delay in filling of arteries will be there, and then delay in the AV transit time will be there, and then venous filling will be slow and low. Then delayed choroidal filling. If choroidal circulation is also gone, you are speaking about retina, right? You know one thing, right? Retina, fundus fluorescence angiography. Choroid, what do you do? ICGA, indocyanine green angiography. This is something which we must remember. So if you are seeing delayed choroidal filling, means choroid blood supply is gone, right? Is gone. So where do you think the occlusion can be there? Go back to your anatomy. You are not having any blood supply to your choroid, so cilioretinal artery is blocked. Or if you are not having any blood supply, you are having defects in fundus fluorescence angiography to retina, then your central retinal artery is blocked. You are having defect here, then you have your ophthalmic artery blockage. Okay. Coming to in late stages, everything will be filled. So you will not see any significant changes. That is one thing which we must be careful. And then autofluorescence imaging, it will be reduced. Electroretinography, reduced Lee wave amplitude. You can just remember. Okay. Next, coming to the most important is your management. So let me discuss management very slowly and clearly. So acute episode. So retinal artery occlusion, when you are getting a case, it is an emergency. You need to remember that this is an emergency, and that requires systemic evaluation also for cerebral vascular accident, because stroke can be there in the same patient. The same patient can be having MI. The same patient can be having risk of having a stroke or MI. So if you're having a patient with acute CREO or BRAO or amaurosis fugax, you need to refer the patient to stroke center for immediate management, because the patient can have stroke also. Okay, so immediately what do you do as an ophthalmologist is you have different measures. Okay, so you check for the intraocular pressure and you found that it is high. So when you are relieving the intraocular pressure, so you have your eyeball. So you have your blood vessel. So when you are decreasing the pressure, na, the pressure on this blood vessel will reduce and this blood vessel will expand. So because of that, reperfusion occurs. So that is the strategy behind reducing your intraocular pressure. So what do you do to reduce intraocular pressure? So you do ocular massage, or you can give IV mannitol, IV acetazolamide 500 mg, or rarely, in very rare cases, very emergency cases, you need to do anterior chamber paracentesis. Simple. Ocular massage, mannitol, acetazolamide, paracentesis. Now you want to relieve. I mean, you can go with any of these, okay? Not all things you need to do, any of these. So measures to reduce angiospasm. So in order to reduce angiosperm, you need to increase mild content of carbon dioxide. So for that, what do? Polythene bag breathing. You need to close the patient head in the polythene bag, or else you ask him to keep his head inside the polythene bag and ask him to breathe. Or else you can give him inhalation of amyl nitrate. Amyl nitrate is used in treatment of another cherry red spot causing thing, that is carbon monoxide poisoning. Next is your inhalation of 5% carbon dioxide and 95% oxygen. So these will reduce your angiospasm. Next is your measures to control your arterial diameter, that is they cause vasodilation. So vasodilators examples nitroglycerin, isosorbate dinitrate, and rarely retrobulbar injection of acetylcholine. Simple, right? Next, you have your thrombus or embolus in the blood vessel. You need to lyse it or you need to kill it. Because of that, you need to damage that. So use fibrinolytics or laser photo disruption. If a patient is a known case of giant cell arteritis, you need to give IV steroids. Urgently you need to give because the patient is already in exacerbation of the disease. So post emergency workup. So you have solved the emergency situation. Now post emergency, you don't know what kind of case it is, so you are working up. So if the age is more than 50 years, age is less than 50 years. So age is more than 50 years. Now this is a very random number that is given in websites. So sometimes the MI and things can come in 30-year age also. So this is just a random number. So you do ESR, CRP, CBC and platelet count to rule out giant cell arteritis. And you need to also assess for the other symptoms of giant cell arteritis also. You will do lipid profile ECG to rule out atherosclerosis. If you are seeing in a very young child, what do you suspect? You need to go with hypercoagulability workup, which include antiphospholipid antibody syndrome or autoimmune conditions or some inflammatory disorders or some any other hypercoagulable states are there or not. If a young patient is having multiple BRAOs, then Susak syndrome should be considered. Susak syndrome. So what do you have in Susak syndrome? Sensory neural hearing loss, retinal artery occlusion, and one more thing will be there. That one we need to find out. Okay. So it's a triad. So you have to find out. Okay. So you need to manage the causative factor. Once you found out the causative factor also has to be managed because the patient will again and again get the same issues. Then prognosis, the visual loss with CRAO is severe, right? It is strongly correlated with amount of retinal edema present. If more retinal edema is present, more vision loss will definitely be there. So CRAOs with the presence of cilioretinal artery sparing, visual acuity is usually recover. Cilioretinal artery is there, macula is okay, so recovery is possible. So that much you can remember in prognosis. Complications, ischemic conditions, right? So you'll have neovascularization. I hope you understood the subject. Thank you.